And we are really very honored to have Professor Victoria Baranov here to give the plenary talk. And uh, I am delighted to introduce Victoria, the plenary speaker. Victoria Baranov is an associate professor of economics at the University of Melbourne, an affiliate of the Center for Market Design and CEPR, and a research fellow at the Life Course Center and IZA. So, Victoria, you've got a lot of hats, I guess, or affiliations. So it's good to meet you. Victoria received her PhD in economics from the University of Chicago. Her research focuses on the role of health, particularly psychological health, in the persistence of poverty. Her work has been published in leading journals such as the American Economic Review, American Economic Journal, Applied Economics, as well as the Journal of Health Economics and other peer-reviewed journals across multiple disciplines. We are pleased to have Dr. Baranov as our plenary speaker this year, as I said, for the third Applied Development Economics Conference, which is co-organized by the Lahore School of Economics, the International Growth Center, and the Consortium for Development Policy Research. She will be talking on maternal depression, parental investment, and child development. Victoria, welcome, and over to you.
Awesome. Thank you so much, Navid. Thank you for having me and inviting me. I'm so honored to be here and to speak to you all today. So let me go ahead and share my screen. And everyone can see that? Yep. Okay, great.
Yes.
That's it. Please go ahead and ask questions throughout the talk. I'll see if I can monitor the chat as much as I can. I will monitor the chat, but but feel free to sort of raise your hand or just interrupt as you go. So great, as I said, I'm really honored to be giving this plenary here at Lahore School of Economics, and I am at CREB because the work that I'll be talking about today is on, as Navid said, on maternal depression, parental investment, and child development. And a lot of the projects that I'll be talking about today took place actually in Pakistan. So here's a photo, as you can see in the background, from some of our more recent work of the Thinking Healthy program, peer-delivered program. So I'll be talking about today. But before I get into specifically talking about maternal depression, I want to start by talking about why we should care, as development economists, we should care about mental health more broadly. So we should care about mental health more broadly because it's a first order measure of welfare. So we obviously care about it just because we care about how well people are doing. But also mental ill health, in particular depression and anxiety, account for about 8% of years lived with a disability. And so it's a really big portion of ill health in general, and we have about 3 to 4% of the global population is currently experiencing depression or anxiety. So it's really, really prevalent in terms of poor health. But in addition to this first order measure of welfare, and so caring about it for that reason, we also care about it because of the potential for this, what's the psychological poverty trap. The idea that poverty leads to poor mental health, and then poor mental health, by impacting the way people make decisions, for example, by reducing effort or labor supply or reducing productivity, might make people stay in poverty. And so then the feedback cycle continues. So this psychological poverty trap sort of was introduced by Haushofer and Fair in their science article. And then actually this image here, I meant to put a source, is from the Ridley et al. 2020 science paper that also talks about the poverty trap. But the two components of the poverty trap that we need are for there to be a causal link between poverty and poor health. And we actually have here quite a bit of evidence on that, because we have evidence on how negative income shocks and poverty cause mental ill health like depression and suicide rates, as this paper shows by Christian et al. But also we have a lot of interventions like cash transfer interventions, so RCTs, so really good clean causal evidence that shows that alleviating poverty by giving access to cash transfers reduces depression rates and anxiety disorders. So we have good evidence on this causal link here, but in order for there to be a feedback cycle, a vicious cycle for the psychological poverty trap to exist, we also need to know that mental illness can affect economic decision making in ways that reinforce poverty. And that, I think, the question is a little bit more open about whether or not we have great evidence on that. We're only starting to, that evidence is only starting to emerge. And so that is what I'm going to be talking about today. I'm going to be talking about two studies that I've conducted where we look at how the causal evidence of mood and anxiety disorders on, in particular, economic decision-making, women's empowerment, and childhood development by looking at interventions that treat maternal depression. And these are randomized interventions. So then we have causal evidence, at least on the impacts of treatment of mental disorders and how that influences economic decision making, and whether that is sort of providing us some evidence on this negative feedback cycle that might be happening. Okay, so just the roadmap very briefly. First, I'll talk about this first trial, which is evaluating the Thinking Healthy program. And it's this paper looks at the long-term impact of treating this maternal depression using the Thinking Healthy program. I'll show you the impacts on maternal depression trajectories, and then look at the mother's decision-making and also child development. And then the second trial that I'll talk about is going to be a completely different trial that is evaluating the impact of a slightly different program called the Thinking Healthy program, peer delivered. As you can tell by the name, it's slightly different because it's peer delivered as opposed to what will be, I'll tell you about, is community health worker delivered. And in this study, what we're going to add in addition to a shorter evaluations in the short term, and as opposed to the long term, we're also going to be including biomarkers, in particular HPA axis hormones, which are, so this is HPA axis is responsible for the stress response, and I'll talk about that in a bit, and how the trial impacts mothers and infants' hormones, so that we can see whether depression interventions might sort of quote unquote get under the skin, and whether perhaps we could use biomarkers as ways to help us see the mechanisms of action, but also detect intervention effects when other times it might be difficult because measurements are difficult. If I have time, which I might not, I might mention a few other RCTs that are not specifically targeted at maternal depression. Well, we have learned that there's related since these other since these papers have, or this work has been done, and then I'll conclude. Okay, so the first paper that I'll talk about, this is joint work with Sonia Balocha, who some of you know, Pietro Baroli, and Joanna Masalco, also known as Asha. And this work has been done with a lot of sort of help and support, but in particular, this intervention, the Thinking Healthy program, was developed by Atif Rahman, and also implemented in large part by Sihan Sikandar. And so although they're not named authors, they are instrumental in this intervention, as well as in the next one, as I'll talk about. Okay, so here in this paper, we're going to be assessing how treating maternal depression affects women's decision-making. And so why do we care about maternal depression in particular? Well, first, I just talked about the poverty trap story, but in particular, sort of extra care about maternal depression because there is a young child involved as well. And so all of the decisions that the mother makes also impact, of course, the early childhood environment for the, the infant and the child, which we know is critical. So in addition to sort of the impacts on decision making that we care about for poverty for the mother, we also care about this intergenerational transmission that we think might be quite important. Also, the prevalence of maternal depression in developing countries is extremely high, estimated to be about 20%, which is higher than depression in general. And additionally, it's largely untreated despite the existence of effective treatment. So what we do in this paper is we leverage a randomized control trial that provided cognitive behavioral therapy, or CBT, for perinatal depression in rural Pakistan, in Punjab. And this was delivered by local health workers, or what's known as lady health workers. It's meant to be low cost and scalable. And here I'll mention scalable in quotes because although it was low cost, lady health workers are a very scarce resource. And so subsequent trials are try to move away from the lady health worker model and try to train peers instead of health workers to make it actually more scalable. So what we know about this randomized control trial that was already conducted and evaluated in the short run is that it was very effective in reducing depression. So what we did is we followed up 7 years after the intervention concluded, and we gathered a rich set of measurements on mothers, on the women's decision making, to look at her financial empowerment, so things like labor supply, the control of her household spending. Then we look at investment in children, so time and monetary inputs. We look at fertility decisions, and of course we look at child development across 3 domains, so cognitive, social, emotional, and physical domains. Okay, so let me tell you about the program. So this is the Thinking Healthy program, which is cognitive behavioral therapy based, and it's aimed to identify and modify cognitive distortions that are common in depression. Things like, I'm a bad mother, my baby doesn't like me, those types of things. And so it's meant to identify these distortions or things that mothers might be ruminating over, and use instead of pictorial and verbal messaging to facilitate healthy thinking. So as I mentioned, this intervention was delivered by trained community health workers in rural Pakistan, in rural Punjab. And this is actually one of the largest psychotherapy trials that has been ever conducted in the world. So some bigger ones have happened since then, but certainly at the time of writing up this paper, it was one of the largest. So THP was adopted as the model for care for maternal depression by the WHO in 2015 as well. So this is a pretty influential program. Let me give you a very quick overview of the timeline and of both the trial and the follow-ups that we'll be using and how the sample was constructed. So basically all women in the 3rd trimester of pregnancy were actually assessed for depression, and all women who were clinically depressed were included in the trial. So we had 20 treated clusters and 20 control clusters. A cluster is a union council in this case, and both arms received 16 home visits, starting with about 1 month before the baby was due, up until 10 months postpartum. Both arms received 16 home visits, but only the treated group received this additional CBT component. The control group just received regular sort of health visits that they would have from the community health workers, from the lady health workers, although they're at an increased frequency than what would be normally experienced in the setting. So what we did is we came back basically 7 years later. 7 years later, we followed up. Originally, the sample was about 900 women that were included in the RCT in the trial, and we successfully located about close to 600 of them, which is about 65%. So that looks like a really bad attrition rate, but it actually isn't as bad as it seems, because not all women were actually targeted for, so a lot of the women were, like 20% of the attrition is due to is excluded in the first year, and so these women were not actually followed up for in between the the 1 year follow-up and what we call the 7-year follow-up. But anyway, attrition is not correlated with treatment status, and our results are all robust to various attrition corrections. So what we did is we have now these women at the 7-year follow-up who at baseline were all clinically depressed, and half of which were treated for depression. So we have a treated depressed group that was treated, a depressed group that was not treated. And then we also actually followed up with 300 dyads from the over 3,000 women who at baseline were not depressed. So now we have a comparison that we call the healthy comparison group, in that they were healthy at baseline. Of course, we don't have all of their trajectories in between, but at starting point, they were healthy. So they give us a little bit of a benchmark. So sometimes I'll talk about the depression gap. The depression gap is just the difference between the depressed controls, the women who did not receive the intervention and who were depressed at baseline, as compared to those who were healthy at baseline. So it's just an OLS, or rather it is a, endogenous comparison that would, compare, that just give you sort of the depression gap, that, how much worse off are, say, the children of depressed women when they're not treated by comparison to the healthy comparison group children. And this, of course, confounds a bunch of other correlation, like a bunch of other things that are correlated with depression, such as, SES, education and income and so on, which are correlated with depression. But it gives us perhaps an upper bound of perhaps the treatment effect that we'd be hoping to see. Okay, so just to first look at the effect of the intervention on depression. And so these results, the first year results were published in the Lancet. And as I mentioned, the intervention very successfully reduced depression rates of the treated women as compared to the control group. This is a 33 percentage point reduction in depression rates 6 months postpartum, and it's persisted to 1 year postpartum. At the 7-year follow-up, what we see is that the control group is starting to get less depressed. So, there is some spontaneous recovery that continues as we would expect, but the treated group remains still lower than the control group, and this difference is statistically significant. And also, so this is about a 6 percentage point reduction in depression. That's about a 17% reduction, even at 7 years. And so if you want to think about what's the overall effect on depression, it's not here at the 7-year difference, it's not the 1 year difference, but rather it's the difference if we were to sort of actually expand this graph so that it is, the time is sort of going at the right pace here, right? So this would be stretched out by a lot. It would be the total effect on depression would be the difference between these two, the difference in the integrals between these two curves, right? This whole area in between, between these two curves, that's the full effect of the intervention on the reduction on depression. So let me remind you that the intervention concluded around here, and that all of these results is just the persistent effect of this one-off intervention, and nothing happened in between. No other follow-ups, no booster sessions or anything. So it's pretty remarkable that we still see substantial effects on depression. Now, when we look at the effects on other mothers' decision-making and child outcomes, let me focus your attention first on mothers' decision-making. The results in the black bars indicate the magnitude of the results in standard deviations relative to the control group, and the 95% confidence intervals with the little marker there that's indicating, oh, sorry, the 95% confidence interval is the one that the very edge. So this is for the full sample in black. And then we split the sample by whether the index child, the child who was in utero at the start of the intervention, was a female or boy or girl. And so we went with the gender normative colors here for ease of reading, I guess. Okay, so what we see overall is very large persistent effects on mothers' financial empowerment. So a lot of these variables include control, and the variables that are really sort of affected in these indices is actually control over spending in the household. This is what we really see improving, and it improves both in the short run, so like at 6 months and 1 year, but actually we see persistent, exactly the same effects at the 7-year follow-up. And then we see effects on parental investment, monetary investment, similar orders of magnitude. So here we see about a 0.3 standard deviation increase in financial empowerment, and about a 0.3 standard deviation increase in monetary investment. We see slightly lower, but still statistically significant increase in time investment, but we don't see any results on parenting style or fertility. So what we also see, and what I'll dig into a little bit in a second, is that we see increases that are much larger for mothers of girls than mothers of boys. And so we see much larger effects for mothers of girls and for empowerment. And we see that this is echoed or paralleled for monetary investment, where these effects are statistically different from the effects on mothers of boys. And we see slightly less of a heterogeneity for time intensive investment. So the heterogeneity in the result by parental investment, on parental monetary investment, this is consistent with a model of mothers getting more bargaining power in the household as a result of intervention, and spending more monetary resources on girls in particular, is consistent with a model of household bargaining where you also have considerable son preference, but the son preference is weaker for the mother than it is for the father. But we also do see that the empowerment results also are different by gender. So that means that the impact of there is actually an impact of the gender of the child on the empowerment trajectories of the mother. So if we see the control trends are in blue for the control group, you can see that for mothers of girls, you see a decline in empowerment relative to the trend that you see for mothers of boys over time. So the reason this is grayed out in the 1 year is that these are slightly different measures. The question's asked slightly differently than in the other years. And so the level, like the difference is meaningful between the treatment and control group, but the level relative to others is different just because of the way the question was asked slightly differently. But basically what we see is that the intervention makes the empowerment of mothers catch up to the empowerment for those mothers who were not depressed, or mothers who had boys, basically. So we see this sort of catching up of mothers who had girls, in particular in that 7-year mark. But we do see this decline. And so this is probably consistent again with this setting in rural Pakistan, where there's a strong preference for boys, and so mothers who bear girls are sort of disempowered over time within the household. And what we see is that the intervention curbs that. Okay, next, looking at child outcomes, we overall see very modest effects. So we see positive effects on physical development and cognitive development, but these are not statistically significant. They're slightly larger for girls than they are for boys, but even the girl effects, despite seeing all of these impacts on parental investment and time and monetary investment, this is 7 years later, despite these persistent effects of the intervention on maternal depression and parenting, we are not able to detect these effects on girls even. And if anything, we see slightly negative effects on socio-emotional development, which we think is due to the fact that socio-emotional development is measured by mothers' self-report. And of course, the mothers partook in a psychosocial intervention, which might bring their attention to to pay attention to the socio-emotional development. And we think that this intervention basically affected the reporting for socio-emotional development. And this, by the way, is the leading hypothesized domain where we think that we're going to see the most effects actually of this intervention. So we think that treating maternal depression is most likely first and foremost to affect the socio-emotional development of the child more than perhaps the cognitive and physical domains. What we do see actually is evidence of, and this is still weak evidence, but a little bit of it is that in the sibling survival, we do see a bit more survival in this context. But this is, I would say, just a interesting finding, but I would say it's still a weak one. Okay, so why don't we see evidence of effects on children? And so what I do here is I'm plotting the treatment effect that we observe and comparing that to the depression gap. So again, the difference between the outcomes for mothers who were depressed and in the control group, not treated, comparing those to the women that were healthy at baseline. So this is sort of like a best case scenario comparison. And what we see is that places that had in domains where we see the largest depression gap is where we see significant effects of the intervention. And places that didn't have a large depression gap, for example, parenting style and cognitive development, is also where our treatment effect that we observe is also the smallest. I'll note that here, again, I talked about the socio-emotional development. This is where things go kind of backwards. We see, a negative effect of the intervention, and this is likely due to reporting. But this is consistent with the idea that, these domains basically, so especially for the children's physical, cognitive, socio-emotional development in particular are, because we don't see massive differences in the depression gap, where perhaps these measures are not as sensitive as we want for this effect of depression to take hold. So this is foreshadowing a bit what I'll talk about in the next paper. So last, we look at potential mediators of this treatment effect, what might be happening in the interim after we've treated mother's depression that might be explaining the results on empowerment and also on parental investments, and also potentially on the lack of effects on child development. So what we see is, in terms of mediators, we don't see any evidence that mother's physical health, the husband's income trajectory, the relationship quality, any of these really had strong, significant effects. So a lot of these are trajectories. Actually, they're all trajectories. So they're all including measures that are both in the short run and in the long run. We really don't see any evidence, any significant evidence that these are driving the results. The thing that we do see quite a bit of evidence for is that mothers who were treated report greater social support, and this is true throughout the period of observation over the entire time. They report 0.5 standard deviations greater social support, and that's really an impressive amount. And that's potentially what's going on, is that women are able to find greater social support. A lot of this actually is due to the mother-in-law. I know you would all be a bit surprised, but it's the mother-in-law that is stepping in and actually helping the women. So as I mentioned, there's no effect on fertility or birth spacing. So here is just a plot of the number of children since the start of the intervention, and this is children in addition to the index child. And what we see is that there's no difference in the number or the birth spacing. So these two lines are right over top of each other. And this looks exactly the same if we separate it out by whether the index child was a boy or a girl. We see similar patterns between treatment and control groups. Okay, so just to summarize quickly on this paper, what we've shown is that this intervention had persistent effects, and it improved mothers' financial autonomy and parental investment. And we have substantively large effects that close the raw gap. And so what this paper does is it provides some of the first causal evidence of the economic impacts of the depression treatment. And as I argued in the beginning of this talk, we really care more broadly about this question about how depression impacts decision-making. And this provides us with it's not the first, but some of the first causal evidence on this, and a really impressive way where there are a lot of measures and a lot of objectively measured outcomes as well that I sort of didn't really talk about, but a lot of the measures on child investment that we have are actually measured by interviewers as opposed to self-report. So we did also find that we have limited detectable effects on child development. And this opens the question as to why this might be the case. Are potentially limited effects on child development due to poor measurement, and whether we can identify better markers for, in particular, early child development and early child socio-emotional development. Another question that we might have is, does treating mother's depression have any physiological effects on the mother? So that's one of the other sort of questions that we'll try to tackle in the next paper.